to our other participants. So give us just 2 minutes so that we can sort our speaker's audio.
Good morning.
Good morning. Can you hear us?
Can everybody hear me?
Yes.
I'm sorry for this delay. It was out of some technical issues. Good morning for you all. This is me, Dr. Mohammad Mustafa. I thank Dear Juwayriya, Dear Monisha, Dear Harita, and all the great team standing behind the Association of Clinical Neurology and Mental Health for organizing this meeting. I would like to make sure that you can hear me well. For those who can hear me well, please type 1 in the chat box, please.
Doctor, thank you for your introduction about yourself. And, it has been a wonderful moment getting to know about you. And we are happy that the audio is audible for all in this. And so Doctor has introduced himself. And with that, we would just be proceeding with the session in it. So before we start off with Dr. Mohammad's session, I have a few words to say about our organizers. Now, Association for Clinical Neurology and Mental Health is a professional association caring for people. Shortly known as ACNM, is an international forum for doctors, medical practitioners, research scholars, scientists for sharing knowledge and innovation in the field of neuroscience, neurology, and neurosurgery. ACNM aims to bring together doctors and medical practitioners to encourage intellectual development and providing opportunities for networking and collaboration. ACNM meets with its objectives through academic networking, meetings, conferences, projects, and publications, academic awards and scholarships as well. ACNM strives to enrich from its diverse group of advisory members. ACNM also delivers access to its members the industry's most essential information by organizing conferences, workshops, annual conventions, meetings, and providing a networking opportunities for both locally and globally. Members can stay current in their chosen profession, connect with their peers, and invest in their future. As you can see, ACNM invests a lot in letting their peers and colleagues know to stay on top of the latest innovations and inventions that happen in it. Association of Clinical Neurology and Mental Health is dedicated to the cause of educating society on mental health and neurological disorders. We believe in an inclusive society. On this World Down Syndrome Day, observed on 21st March 2022, ACNM organizes a free webinar session to educate our society about the challenges faced by people living with Down syndrome and the importance of developing compassion towards people with special needs. Together, let us strive to improve the quality of life for people with Down syndrome. And on that note, I would like to welcome today all our dignitaries, members, students, and all our participants to our wonderful webinar session. Our association president is Dr. A.V. Srinivasan. He is currently working as an emeritus professor, Dr. MGR Medical University, and former President, Indian Academy of Neurology, Tamil Nadu, India. Now, it gives me immense pleasure to announce our keynote speakers for today. And in short, let me introduce you our keynote speakers. Our first keynote speaker is Mr. Mohammad Mustafa. He is currently working as a neurology specialist on Paradise Neurology and Rehabilitation Clinics, Alexandria, Egypt. Thank you, sir, for joining all the way from around the world. It's really a pleasure to have you with us.
Thank you.
So over to you, doctor, and the floor is yours.
Thank you. So good morning or good afternoon, according to where you are currently. My name is Dr. Mohammad Mustafa. I've been working as a neurology specialist in the field of Down syndrome for many years. And I thank all the organizing committees standing behind the Association of Clinical Neurology and Mental Health. Thank you, Dear Joaria. I thank Monisha, and I thank all the audience for helping us to achieve this possible webinar. Also, I thank my colleagues, Dr. Ram and Mr. Sandeep. They are the next to come speakers. I would like today to give you a few hints about the neurological manifestation of Down syndrome. As we know, we have on the average around 400,000 patients with Down syndrome only in the United States of America. We have an average prevalence of one child with Down syndrome in 100 live births to 1,000 live births. Of course, you cannot imagine how much is global, economical, and the neurological the burdens that families face with Down syndrome. As I am the first speaker, I should give you a few hints about Down syndrome as an orientation. Down syndrome is the most common cause of mental retardation or mental subnormality. As you see here in the picture, Down syndrome is characterized by a set of dysmorphic features and multi-systemic features. That's why it was called a syndrome. Of course, we know all the known skin manifestations which can help us to recognize, like the hypertelorism, like the low-sit ears, like the specific features in the palm and hand. And of course, we know that there are risk factors well established now that can cause Down syndrome, including all maternal age at presentation and some cases of preeclampsia and many other associations known to cause Down syndrome. So today I'm not going to delve into this for respecting the time of my two other colleagues. I'm going to go directly into the neurological complications of Down syndrome. Most of the work I'm going to present today stems from a review article published in 2020 at the University of South California by dear colleague Dr. Santoro and the other colleagues. And I would like again to thank you all for participation, from Ms. Monisha to Harita to Dear Joiria, to all the army standing behind the achievement of this day. So what are we going to discuss today? We're going to discuss three important topics. What are the neurological manifestations of Down syndrome? What are the psychiatric manifestations of Down syndrome? And the updates in the management of Down syndrome, is there is a hope in the end of the tunnel or not? For neurological manifestation of Down syndrome, there are key four neurological manifestations, starting from cerebrovascular disease to epilepsy, atlantoaxial instability, and hypotonia. Starting first with cerebrovascular disease, we have two known associations well established over the last 2 decades that most patients with Down syndrome present with. The first is stroke, ischemic stroke, which is the Moya-Moya syndrome. Moya-Moya syndrome, in short, is a disease characterized by progressive narrowing of the blood vessels in the brain. If you can see here in the picture, this is the internal carotid artery. In the end of the internal carotid artery, there is a narrowing which is progressive over the years. This narrowing results in collateral formation, and these collateral formations, unfortunately, are not adequate to supply the brain, leading to these children, even before the age of 30 years, presenting with strokes, preventing with hemiplegia, preventing with aphasia. Can you believe that a child with Down syndrome having a stroke, and most of the time it's a double stroke, so he has bilateral hemiparesis. So you can imagine the amount of the burdens that the family faces to recognize, to diagnose, and to get the child treated. That's why awareness in World Down Day is very important. We should make everyone aware of this complication to prevent them before they occur. Successfully, the prognosis of Moya-Moya syndrome is good thanks to the advancement in the management today, ranging from medical treatment to vascular bypass surgery. The other complication known for cerebrovascular disease Down syndrome is cerebral amyloid angiopathy. Cerebral amyloid angiopathy, as you see here in the picture, it's a hemorrhagic disease, and in the contrast to Moya-Moya syndrome. Moya-Moya syndrome, most cases present with ischemic stroke. Unlike the cerebral amyloid angiopathy, they tend to present with hemorrhage. So hemorrhage can take the form of only microbleeds to the massive lobar hemorrhage. What is the reason for this hemorrhage? If you remember that trisomy 21 is a mere reason for Down syndrome. This gene encodes, in addition, for a protein called amyloid precursor protein. This amyloid precursor protein is a cell membrane protein, which is important for the formation of blood vessel. As we will see later in the Alzheimer's disease associated with the Down syndrome, this protein so far has not been established and understood in a deeper insight. That's why this protein, when it gets disturbed, it tends to malformation of the blood vessels, leading to rupture and a possible hemorrhage. Unfortunately, there is no current treatment for cerebral amyloid angiopathy apart from supportive treatment. Epilepsy is another very important association in Down syndrome. Actually, patients with Down syndrome are more liable than general population to develop epilepsy, especially the early onset epilepsy before the age of 30 years. We have two known syndromes associated with Down syndrome. The first is the infantile spasm. Infantile spasm, as you can see here, this child is taking the extensor attitude. You can find a child in the age of 6 months to 1 year presenting with repeated extensor spasm, repeated flexor spasm, or sometimes status epilepticus. And the EEG here, we can find a common, very characteristic feature is called hypsarrhythmia, which is a slowing of the background admixed with epileptiform discharge. This syndrome is the most difficult epilepsy syndromes to treat, and you can believe that a child with before the age of 1 year developing this horrible syndrome, and treatments so far, it can produce control in only 1/3 of the children. So this is again arises the importance of prevention, of giving awareness to all people how we know about Down syndrome, and we hope in the future treatments can develop to prevent such unfortunate outcomes for Down patients. As you know, the average life expectancy for Down syndrome is 60 years, and so every effort should be held, and all help is needed. The other epilepsy syndrome in children is called the Lennox-Gastaut syndrome. The main difference between Lennox-Gastaut syndrome and the infantile spasm or West syndrome is the age. The age of Lennox-Gastaut syndrome is older, ranges around 5 to 7 years, and they tend to present with multiple manifestations of epilepsy, including absence seizure, atonic seizure, tonic seizure, clonic-tonic, or atypical absence. As you can see here, this is a normal EEG with a classic alpha background. And if you see here, there is a spike and wave pattern, which is a slow spike and wave pattern. This is very characteristic of Lennox-Gastaut syndrome. And again, Lennox-Gastaut syndrome has a high rate of intellectual disability, learning disabilities, and the surgery has guarded prognosis, including neurosurgical interventions such as resection of corpus callosum or subbile transections. Late onset epilepsy is not as frequent as early onset epilepsy, but we see often some cases above the age of 30 years. They vary from partial onset epilepsy to generalized tonic-clonic seizures, and the gold standard treatment, of course, is the anti-epileptic treatment. Also, hypotonia and atlantoaxial instability are very important associations of Down syndrome to be known. Hypotonia is a very important cause of delayed milestones, especially the motor milestones and failure to thrive, because the patients with children with Down syndrome cannot swallow well, cannot walk well because of this hypotonia. It can happen up to 80% of Down syndrome children. Atlantoaxial instability, on the contrary, is a cause for hypertonia or upper motor neuron signs. That is to say, when you find patients with Down syndrome, especially around the teenage period. Yes.
Sorry to interrupt you. We just have a participant raising their hand.
Okay.
So Sarita, you've raised your hand.
Yeah, sure, please. Yeah, sure.
Sarita? Are you there? You've raised your hand. Do you have any doubts or any queries?
Actually, if possible, can we postpone questions till the end of the lecture? And I'm very ready to answer all questions and queries. Because,
sure, of course, doctor. So, Sarita, whatever question or doubt you had, you could just park your question for the later on at the Q&A session. Thank you.
Thank you.
Please,
Thank
doctor,
you,
continue.
Yeah. So atlantoaxial instability, on the contrary, that it occurs in the teenage period. and it happens in 10 to 15% of the Down syndrome. And as you see here in the picture, this is a picture of an anesthesiologist trying to intubate a patient. Why I'm presenting this picture? So that you can remember always, when you see a patient with Down syndrome who is going to do a surgery, he should inform the surgeon beforehand that he has this condition. This condition, it happens at the cervical spine. It gets lax. So if the anesthesiologist is not aware of that, during extension of the neck in intubation, it may break the spine and causing permanent quadriplegia. And of course, we don't want this complication to happen to dear Down patients. That's why it's a very important preventive message to know. Lastly, I will go shortly through this because my main concern is neurological manifestations, the psychiatric manifestation of Down syndrome. Intellectual disability, as I informed you, is that Down syndrome is the most common cause of intellectual disability. And many approaches have been done to treat this intellectual disability. And of course, there is individualized treatment for such a condition. Hearing and visual impairment is a very important aspect to know. The most common cause of hearing impairment is otitis media with effusion, leading to conductive hearing loss. It occurs in 85% of Down children. And again, this is preventable complication. Visual impairment, again, is caused by refractive errors, squint, happening in 43% of Down syndrome patients. And again, it can be prevented. Disorders of attention like ADHD are very common and needs prompt recognition. In addition to autistic spectrum disorders leading to social communication defects, again, is a recognizable and treatable and preventable disorder. Very importantly, we should know Alzheimer's disease is very frequent in patients with Down syndrome, and they tend to present younger than normal population. Usually the age of onset is 55 years old. If we remember, see here in the picture, you can see these are the normal neurons, and these are the cause of the Down syndrome so far. That's something we call the beta amyloid plaques and the tau fibrillary tangle deposition. Let's go to this next slide to explain this. If you see here, these are the normal neurons. As you see here, a set of fibers wrapped by a nerve sheath. And you see here, there is a cell membrane protein called the tau protein. In cases of Down syndrome, this tau protein gets hyperphosphorylated. And this hyperphosphorylation makes the tau protein like a block, causes a block for the signal transduction across multiple neurons, leading to neuronal death in the end. And amyloid plaques, if we remember the amyloid precursor protein I have noted earlier in cerebral amyloid angiopathy, these are precursor proteins that should be broken in a proper way to produce a soluble amyloid proteins. Unfortunately, this does not happen in cases of Down syndrome, and leading to precipitation of insoluble forms of amyloid proteins, leading to, again, neuronal death, and causing, if you see here, the synaptic miscommunication because of these debris not washed out. Of course, Alzheimer's disease is very important to recognize, and there are treatments currently leading to slowing the progression of Down syndrome, including the acetylcholine enhancers and NAMDA antagonists. And other psychiatric manifestations of Down syndrome include depression, which happens in 11% of Down patients, including at the age of 29 years old usually. There is a catatonia, which is a condition of dopamine depletion syndrome in the brain, leading the patient, as you see in the picture here, to attitude-specific positions and associated with disturbed sensorium. And these conditions are commonly associated with other medical illnesses like hypothyroidism or AIDS. So it's very important when a Down syndrome patient presents with such feature to recognize and to treat accordingly. Finally, it's very rare syndrome, but we can see it. It's Down syndrome regression. It's a combination of catatonia and depression, but in a rapid onset. We believe that this syndrome is autoimmune in origin. That's why one of the effective treatment is antipsychotic, antidepressant, and IVIG administration. Catatonia treatment is mainly treated by benzodiazepine and electroconvulsive therapy for uncontrolled cases. Finally, there is a hope in the end of the tunnel. There are many trials conducted for providing updated management of Down syndrome. We can hint here that the National Institute of Health has made a campaign called Include campaign, which is investigation of concurrent conditions across the lifespan to understand Down syndrome. Since 2011, many research has been conducted with INH as well as in the MIT technology. And we hope in the next future, we can have better prevention and treatments for Down syndromes that can make the life expectancy instead of 60 years old can be longer. And the go-home message that Down syndrome, though it's still untreatable, but there are preventable milestones in the way, as I mentioned in the lecture. I thank you all for listening, and I'm ready to answer all questions that are available. Thank you all, and I thank the Association for Clinical Neurology and Mental Health staff for providing me this chance.
Thank you, Doctor. Thank you for the wonderful session on Down syndrome awareness. I'm sure everyone over here found the session to be informative as well as educational. Now I open the floor to any queries or any doubts. So we originally had a hand raise from Ms. Sarita. So if you're in the session, if you're present, could you please present your question to the speaker?
Yes.
Right. Ms. Sarita, are you there? Okay, the floor is open to any other participants as well. You can go ahead with your questions or your queries. You can even put it up in the chat box if you're not able to say it out loud as well. Yes, our doctor is eagerly waiting for any of your queries, if you do have them. All right. So we can always come back later to the questions if they have been typed in the chat box. Yes, we can come back to that. And thank you, Doctor, again, once again, for the wonderful session. And we'll have an eye on the chat box. So if any of them have any questions, we'll note them down and have them addressed after this. Now, on that note, moving forward to our next speaker. So Dr. Rambabu Pyari, he is a consultant pediatrician and also a neonatologist, and he is from Andhra Pradesh, India. Now he represents Ujjwal Madhuravada Hospital in Vishakhapatnam. Doctor, thank you so much for joining today and giving us a part of your wonderful time. And we are sure that your contribution will also add to World Down Syndrome Day. So the floor is yours, sir. Thank you.
Good morning, all. Sorry, my laptop was stuck with the camera. My camera is with phone, and I'm speaking my topic on laptop. Okay. So my topic today is, are you able to hear me? Hello?
Yes, I can hear you, Dr. Ram.
Okay. Yes, my topic today is Down syndrome. Specifically, I'm talking about leukemia. So basically, Down syndrome is caused by trisomy 21. That means there are 3 copies of chromosome 21 instead of usual 2 copies. Everybody will have 2 copies. Here we have 3 copies of 21 chromosome. That is the basic defect in Down syndrome. That is a chromosomal defect. So here, when we see this, what we call it is a pathogenesis or the cause of Down syndrome. The normal process of meiosis, it causes 44 chromosomes in 95% of cases. But here what happens is 23 and 23. But one copy, it has 24 chromosomes. When these 24 chromosomes oocyte combines with 23 chromosomes sperm, then it represents 47 chromosomes in chromosome 21. So that's how it is called as meiotic non-disjunction of chromosome 21. So this is the basic cause of extra chromosome, 47 chromosomes, trisomy 21. So there are defects like physical appearance and intellectual disabilities, developmental delays, sensory abnormalities, congenital heart diseases. Next slide. The same slide. So there are many defects, Alzheimer's disease, GA malformations, thyroid disorders, poor immune system, and leukemia in Down syndrome. Okay, next slide. Next slide, please. In leukemia, what happens is there are four in Down syndrome: myeloid leukemias and lymphoid leukemias. Both in myeloid and lymphoid, there are acute types and chronic types. Okay, so here what happens in myeloids is the next step of progression to myeloid series is disrupted. So only myeloid precursors are present. So that's how there are more myeloid series, and it causes myeloid leukemias, both acute and chronic. The same happens in lymphoid series also. Here also there is a acute phase and chronic phase. So acute leukemias and chronic leukemias. That's how leukemias occur in Down syndrome. Next slide, please. So there are so many famous persons with this Down syndrome, like Chris Burke, who is an actor and folk singer, and Jamie Brewer, he is an actress. She is an actress, and Pablo Pineda, a writer, teacher, and consultant. So disability is not a matter of perception. It is not an obstacle to one's skills and activities. So many people, they have this Down syndrome, and they have progressed well to their activities, and they flourished well. So this is on this floor, we have to encourage all the people with disabilities, including this Down syndrome, to have more capabilities, more strength to come forward. So next slide. There are three types of Down syndrome: trisomy 21, translocation Down syndrome, and mosaic Down syndrome. What happens is trisomy 21 you have seen. This is the most common type. Every cell has three copies of chromosome instead of two. So this is the commonest type. In translocation type, each cell has part of an extra chromosome. Instead of every cell three copies, a part of extra chromosome 21 is there. Mosaic is combination, trisomy 21 and this translocation. When these both types are present, it is called as mosaic Down syndrome. Next slide. So once again, what happens in Down syndrome? Its origin starts from prenatal, means in pregnancy itself. In general terms, the first hit is prenatal. So when the baby is in the womb of the mother prenatally, then itself there is a change in the chromosomes to trisomy 21. Then what happens is the next stage. If it misses that stage, the next stage is GATA1 mutation on X chromosome. That is one type of mutation. And the third hit is there is a stage called transient myelodysplastic disease. Myelodysplastic disease. So this is a mild type. If it survives and delivers the baby is delivered, then it transforms into postnatal, means after delivery, the survival of transient myelodysplastic disease turns into full-blown Down syndrome. That is called the subsequent hits, genetic, full-blown genetic, epigenetic candidates. So here, the silent transient myelodysplastic disease, it has nothing to do. So just it comes, and maybe silent in some persons, may not be detected. Many of the people, they may not be detected with Down syndrome. It becomes a silent one. But when they marry someone and the next generation may be affected. That's how we will see in some families. Suddenly, some person is diagnosed with Down syndrome. They say when you ask the history, oh, nobody in our family has Down syndrome, but there is a transient disease, hidden disease. Okay, so this transient disease, when it comes into postnatal, it comes into Down syndrome. Some cases they clinically resolution is there, and this when it transforms into Down syndrome, less than 20% of cases they have mortality, means they may die of different complications. In other cases, it is transient myeloplastic disease, it persists, and then the treatment is required. In the last stage, when there is after postnatal stage, we have seen subsequently it's genetic and epigenetic candidates when they are fully blown myeloplastic leukemia Down syndrome. That is called as myeloplastic leukemia Down syndrome. That is the stage which requires complete leukemia treatment. Next slide, please. So now we will see what are the signs and symptoms of Down syndrome. Okay, there is a flat face with upward slanted eyes, short neck, abnormally shaped or small ears, tongue may be protruding, small head, deep crease in the palm of the head, and iris of the eye which has 5 spots, and the muscle tone is poor, becomes they are flabby, like you can hold the hand like this, but their hand will be like this, loose ligaments and excessive flexibility. Next slide, please. So here we can see the picture representation. There is an overall growth failure, flat back of the head. The back of the head is flat. We have some bump backside. They have flat. Abnormal ears. Finger, we have some loops, like we will see in the fingerprints. Many loops will be there. The palmar crease. The crease won't be present normally. They will have extra palmar crease. Skin ridge patterns, abnormality. And one ribs will have ribs one side and one side. So there may be unilateral, bilateral absence of one rib. And intestinal blockages that presents congenitally, and umbilical hernias, pelvic abnormalities, muscle tone is diminished, and broad flat face. Face is like some depressed one, slanting eyes, epicanthic eye folds. This is also called as Mongolian slant. Nose may be short, and hands are short and broad. Arched palate. Palate is this one. That is a small and arched one. Big wrinkled tongue. That's how there may be difficulties of speech defects. And dental anomalies. Easily their teeth gets, their dental decay will be there. So heart defects, congenital heart defects, maybe ASD, VSD, septal defects, colon abnormalities, enlarged colon, and big toes widely spaced. That's why the shoes, sandals, shoes, chappals for the Down syndrome patients, the normal chappals they can't wear, because we are wearing chappals because we have that the first and second toe space is normal. Here they have more space. That's why they can't hold that. In chappals they can't wear. They will easily slip out. Next slide, please. So the same thing we have discussed: physical abnormalities, neurological like Alzheimer's disease, thyroid disorders, and leukemias. Next slide, please. Next slide, please. Next slide, please. So the most serious complications of Down syndrome, they are heart defects. We have discussed like atrial septal defects, ventricular septal defects, asymmetric septal hypertrophy, and blood disorders. They are cancers of the blood in general terms. That is leukemia, and also immune system problems. Their immune system is weak and poor. So the children with Down syndrome, they are particularly susceptible to 2 types of leukemias. They are acute megakaryoblast leukemia and big cell acute lymphoblastic leukemias. In them, the most common subtype is acute lymphoblastic leukemia. That is called as ALL. Next slide, please. So children with Down syndrome, they are at an increased risk of developing any type of acute leukemia, but they are 150 times more likely to develop acute myeloid leukemia, and 33 times greater risk of developing acute lymphoblastic leukemia. Next slide, please. The overall Down syndrome patients, out of the children, 2.8% of children with Down syndrome, they develop leukemia. And out of them, by the age of 5, 2.1% they are diagnosed by leukemias. So early detection of these leukemias by frequent screening and routine checkups are required. But once the patients are diagnosed with Down syndrome. Next slide, please. So here, the ones transformed from transient myeloplastic disease, the neonates are born with Down syndrome. Out of them, still transient myeloplastic disease is present in 5 to 10% of cases. And in them, the 20% are silent. There are no specific symptoms. Maybe no transient myeloplastic disease in 70% of cases. But when it comes to transient myeloplastic disease in 5 to 10% of cases, there is a 20% mortality. Means 20% cases, they may progress to different complications, and they may succumb to death. And another 30%, they transform to myeloplastic leukemia, as we have discussed, full-blown myeloplastic leukemia in Down syndrome. Some cases, they have become still silent, but still we have seen some cases, we discussed, some cases may transform to myeloplastic leukemia. Even they are silent, they may transform to myeloplastic leukemia. So then in this myeloplastic leukemia and Down syndrome, 80% of cases, they may survive event-free, means no further complications, with effective chemotherapy. Chemotherapy is giving cancer drugs. And still, even if you give treatment, 20% of cases, they may succumb to death because of so many other genetic prone. They're prone to so many complications because their genetic makeup, and they may succumb to death. Next slide, please. So what happens in transient myeloproliferative disorder? Here, the trisomy 21, how it comes, we have discussed. When this trisomy 21 is including with GATA1 mutation, that transforms into transient myeloproliferative disorder. If they are different, trisomy 21 is different, and no mutation, no transient myeloproliferative disorder. But when it combines trisomy 21 with mutations, that comes as transient myeloproliferative disorder. Fortunately, this may not cause much problem to the patient. It may resolve. Next slide, please. Acute megakaryoblast leukemia. Now you will see what happens in acute megakaryoblast leukemia. Here, what happens is trisomy 21 plus GATA1 mutation is transient myeloproliferative disorder, as we have discussed. When it combines with other mutations, that comes as acute megakaryoblast leukemias. So, in these cases, some cases they may resolve spontaneously, and some cases they may require chemotherapy treatment and survive, and some other cases they are prone for severe complications and they may die. Next slide, please. So overall, individuals with Down syndrome, they have a predisposition to leukemia and other cancers and excess mortality from other conditions. But the more workup and more research was done on leukemia rather than other cancers, because maybe they are causing less, their incidence is less, and they are causing less problems. That's why the magnitude of risk associated with other specific cancers or cause of death is sparse. Next slide, please. So, as you know, Down syndrome is caused by chromosome defect, trisomy 21. But Surekha Ramchandran, founder of Down Syndrome Federation of India, there is a Down Syndrome Federation of India. What happened was, her daughter was diagnosed with this Down syndrome. Then they started this Down Syndrome Federation of India, and they made some studies. In that study, they found increase in stress levels seen in couples during the time of conception. So when they are married and planning for children, planning for pregnancy, in that time, any stress levels, maybe male factors, female factors, family factors, environmental factors, work factors, employment factors, maybe different stress levels, they may cause a direct link. They have a direct link with the causation of Down syndrome. That's why we advise whenever they are planning for pregnancy, maybe they are at risk or not risk Down syndrome, we advise them to be stress-free at their convenient levels. Next slide, please. So there is also one other factor. Women who are 30 years or older, they are at risk of developing, means they are at risk of giving birth to babies with Down syndrome. Okay, so how can we help them? There is a screening at 11 to 14 weeks of pregnancy with first trimester ultrasound. First trimester is first 3 months. Next trimester is next 3 months. Overall 9 months, no? So 11 to 14 weeks. So then there is a first trimester ultrasound and some blood test. Blood test is a screening test. They are quadruple markers, triple markers, like HCG, like the tests. They can be done. And also, again, screening is done at 15 to 20 weeks. Multiple marker serum screening test. Here, according to the levels, we can assess whether this pregnancy results may result in Down syndrome or not. Okay, so whenever a obstetrician comes with babies with mothers with 35 years or older, always advise them to be more cautious, stress-free, and have regular checkups. Whenever they come for checkup, do a ultrasound in first trimester and also a screen test at 15 to 20 weeks by multiple marker screen test, so that they can predict what's happening. Next slide, please. So these many children with heart defects, they may develop pulmonary hypertension. This is a lung damage. Pulmonary hypertension is like BP in blood vessels, BP in lungs, blood pressure in lungs. Whenever it is raised, it causes lung damage. So other issues like hearing loss, vision problems, they are the defects in Down syndrome. That's why they should be screened for regular hearing assessment and regular ocular vision assessment. Next slide, please. So whenever they are planning for pregnancy, like even mothers below 35 years or at risk mothers of more than 35 years, they have to plan ahead. Routinely, we are advising folic acid, everyday folic acid, 400 micrograms of folic acid they have to take, and avoid harmful substances, especially alcohol at the time of pregnancy. So better to adopt a healthy lifestyle. If they are prone for diabetes, They are previously diagnosed, or some cases they are called as gestational diabetes. When the mothers are diagnosed with diabetes during pregnancy, that is called as gestational diabetes. So then we advise them to keep the diabetes under control, normal levels, even with medication. Some safe medications in pregnancy are there. They can use that and maintain a normal diabetic control. So regularly talk with your healthcare provider. That's why the risk mothers above 35 years and other risk diabetes mothers, they have to make frequent visits to the healthcare provider, obstetrician, and take regular advices. Never to neglect any single problem. Next slide, please. So now we will discuss what are the different therapies for Down syndrome, because Down syndrome, when it occurs, there is no definite and permanent cure that comes back. Down syndrome won't be cured completely. So we have to give supportive treatments. What are the different supportive treatments? As we have discussed, they have vision and hearing problems. So speech language therapy. So here, communication and language skills are dealt, and they will focus on articulation. Articulation is I'm speaking or speaking. So that is articulation. They have to train them. Cognitive skills. My cognitive skill is the audience are there. I have to speak about this topic. That is a code. We have to train them. And strengthening the oral muscles, tongue, lips, because these are the things with which we are speaking. So training the children with Down syndrome with all these skills, that is called as overall called as speech language therapy. Physical therapy means we have discussed, they have flabby muscles. So we have to do physiotherapy so that the strength can be improved. Occupational therapy means some persons, they grow up to the adolescence and 20 years. They may choose their own occupations. There, they have to guide them. We have to encourage them and do their best. That is occupational therapy. Assistive technologies. Suppose one Down syndrome patient, he has poor muscle tone in the legs, he cannot walk, and he's capable of doing all the things. He has got a job, so we have to assist him by providing a wheelchair whenever he comes to the office. Give a wheelchair so that he can come by wheelchair and do his activities. We should not say he is not able to walk, so that he is not eligible for that. That should not be there. We have to encourage them. The only disability he has is he cannot walk properly, but his mind is working good. Make use of his mental abilities. Special education. Some Down syndrome patients, they may not be coping up with the normal school activities. We have to give them special education. There are more children with Down syndrome in one area. Let them have one special classroom and give training to the teacher also, and teach them so that they can excel in their own way. Next slide, please. So whenever we treat the Down syndrome patients for leukemia, that there is a phase called intense therapy. We will give intense therapy with all the induction drugs like daunorubicin, cytarabine, and 6-thiagonine. So we have to give lower doses of induction therapy because they cannot tolerate. As we have discussed, they have less immune power. So we have to give lower doses. And we cannot give treatment like other people. We have to give more gap between the treatments. We have to give more time and gap also more time, so that there will be effective treatment and result oriented. It's not like giving the treatment intensively and they cannot tolerate. There are more complications and they may succumb to death. So we have to be vigilant when giving chemotherapy to these Down syndrome patients, especially with leukemia. Next slide, please. There are adverse events with this chemotherapy, like mucositis, means oral mucosa. Mucosa is the mucosa that is inflamed. Infections, the opportunistic infections. this COVID period, all these patients with leukemias and all these patients, they are requiring chemotherapy. They have suffered a lot because if the already opportunistic infections all over the world are there. When I added to this, COVID has come. So if this COVID is affecting these patients, they are more succumb to death because they are less immune, and this infection is has got more mortality. There are so many cases. They have lost their lives. So there is hyperglycemia, blood sugar levels may rise, and these chemotherapy sometimes they may cause that neurological disturbance and seizures may occur. Next slide, please. Next slide. So that's why today also on this Down Syndrome Day, March 21, 2022, Down Syndrome International, they have given an inclusion means program. Inclusion means program. Next slide, please. Means in a UNCRPD, United Nations Conventions on the Rights of Persons with Disabilities. Disability is a means of perception. They doesn't mean they cannot do anything and they cannot be neglected. So they have their own rights. Like any other person, they have the rights that they call for full and effective participation and inclusion in society. They should be encouraged to fully participate in the society and do their best. Next slide, please. So here what they say is everyone should have the same opportunities. Maybe it doesn't mean that one is fully able and no defects, he will excel. And also the vice versa, the person with disabilities, it doesn't mean he won't excel in his own skills. So let us give them the same opportunities. And result is left to their own abilities. So they have to take part in the same activities as other persons, and they can be able to go to the same places as other persons and enjoy the same experience. They are not to be neglected. They also have the right to enjoy all the things in all the facilities with all the other persons. Next slide, please. So in reality, what happens with Down syndrome patients? They do not benefit from full and effective participation in inclusion, maybe due to different reasons. One reason is lack of agreed understanding about what inclusion is and what inclusive system looks like in practice. In this platform and this Down Syndrome Day, all of us should take this message of inclusion criteria. All the persons with Down syndrome, in that matter, any person with any disability, they should not be neglected from all the facilities. They have to be given the same facilities, same encouragement, and we have to see they may participate and they may excel in their own activities. Next slide, please. Next slide. And also, not everyone understands how to include people with Down syndrome and disabilities. So one running competition is there, or walking competition is there, or some small activities. It doesn't mean that we have to include them with normal people and see. We have to take people with all Down syndrome one platform, and we can make them participate. And also, how full inclusion benefits everyone with or without disabilities. How this benefits if we include them, they will be feeling more happy, and their mental abilities will increase, and they will be happy. Oh, we are also the same in the society. We are not away. So that's how their mental abilities also increase. And not everyone understands what is happening around the world to bring about inclusion for all. Maybe in our area, in my place, maybe Down syndrome people, they are neglected. It doesn't mean that all over the world they are doing the same. Then I and we have to learn how to include them in all the activities and encourage them. Next slide, please. So the future therapeutic targets for further study in myeloplastic leukemia Down syndrome is c-KIT inhibition using imatinib. These are the new drugs, and MIR 125B inhibition and interferon therapies. Low dose interferon may restore inhibition of NKP proliferation and may therefore be an effective treatment strategy for residual NKPs in transient myeloplastic disorder. As we have discussed, some silent TMDs, transient myeloproliferative disorders, they may not manifest, but their next generation may be affected. So, how to screen them and give effective treatment to these transient myeloplastic disorders so that the next generation won't be affected. The present concept is how to prevent the further diseases. So that all this research is going on to inhibit, to stop the further progression of the cases. Next slide. So he is Bryce Walker, a Rupert resident. He is the one of the world's oldest surviving Down syndrome patient. He is 76 years old. So now we can understand Down syndrome patients also, they can survive and do their activities as like normal persons. He is an example. Thank you. Thank you for patient listening, all the attendees.
Thank you, Doctor. Thank you for the wonderful session that you have given us and for an in-depth knowledge sharing into Down syndrome awareness. It was very informative. And now let's move on to the Q&A part of the session. So audience, is there any questions, any queries that you would like to post to our doctor? You can even put it in the chat box if you're not able to say it out loud or have any issues with your audience. So let's take it for another 2-3 minutes. So the floor is open for any questions. Right, audience, any questions? Okay, we have a question on the chat box from Sarah Ansari. So thank you for your question, Sarah. Her question is this: any specific evidence-based rehab protocol which is preferred for such patients? So doctor, can you take up this question?
Yeah. So that's what we have discussed. These evidence-based rehab facilities are. We have discussed the speech language therapies, physical therapies, occupational therapies, assistive technologies, and special education. These are all evidence-based only. They can be practiced. The evidence, the live evidence is that a long living person who lived for 76 years. That itself is an evidence, because uh, uh, he was given all the therapies and he was assisted, so that he lived long, that 76 years. I think that is the evidence we got, live evidence.
Okay, Sarah, so I hope that answers your question. Any other questions, please? Okay, doctor. So Sarah has again clarified her doubt. She has says that she wants to understand if there is any protocol that needs to be followed for them. She has emphasized on the word protocol.
Okay, protocol is like we have newborn screening. Whenever the patient is diagnosed with Down syndrome with karyotyping, trisomy 21, like from birth we can screen for hearing, like hearing, and also from first month onwards we can screen for hearing, and the baby's developments from birth to 2 years. There are some visual, hearing, physical, motor skills. Every skill we have to assess. Then, whenever they are not achieving this developmental goal, then we have to intervene. If it is the developmental milestones they are attained normally, we need not intervene. We will see when the child is not able to stand or walk by 1 or 1.5 years, then we have to intervene. Like that is that again depends on different individual child based. One child may attain these milestones late, and one child may attain milestones earlier. So that we'll see whenever that milestone is delayed, any aspect is delayed, then we have to intervene. We know how to do this. We have discussed these therapies. So we have to implement that particular thing in this child. We have to see which milestone is delayed and at what time. So according to age, we have to intervene. Maybe madam is a physiotherapist. She knows well how to do. I'm a medical person. This is the developmental assessment we will do, and we will refer to this specialist physiotherapists like this.
Okay, Sarah, I hope that helps you in understanding about the protocol. So, as our doctor had mentioned, so he's a medical person and you're a neurophysiotherapist. So, perhaps, what he has said would serve as a guide for you in learning more about the protocol. Okay. Thank you, Sarah, for the input you've given us. Okay, can we have any other questions? All right, so we will move on as there are no queries or doubts. So thank you again for your wonderful time and for giving us an in-depth knowledge into World Down Syndrome Awareness for this day's webinar. And thank you to the participants. Now moving along, we have our next keynote speaker, he's Mr. Sandeep Nath. Now he is a founder, virtual broadcaster, speaker, and author of Renewalism, Inner Power, Energy, and Mindfulness Coach. He is from the Greater Delhi area, India. Now, unfortunately, we received word from him at the last minute that he would be unable to give us a session today due to a personal reason, but he has been kind enough to send us a recorded session of his. I'm sure that would be very informative to us. So, give us a minute to share the recording of his session with you in our screens. Okay, please let me know if you can hear the volume.
Thank you. Friends, we're here to talk about an extremely important subject of social inclusion and the social aspects of the Down syndrome. My name is Sandeep Nath, and through the next half an hour, I'm going to take you through a few aspects to think about when it comes to
Just give us a minute.
social inclusion. In fact, what is the problem of inclusion? The problem of social inclusion, if we were to draw two axes, it's about the conversations that we have in society. Now, if we were to populate these axes with social inclusion on the X and conversations, take for example, overweight, right? What we talk about weight loss. Did you know 98% of websites that are dedicated to wellness have huge sections on weight alone? Which means that as an industry, the wellness industry, the health industry, we are giving a lot of importance to this subject. Now let's take another subject. Let's say there's a wound, there's a fracture. There are conversations around it. You have a little wound about this size somewhere in your arm, and it becomes something to talk about, right? All your friends know about it, all your family. You have a story attached to it, how you fell off the scooter, whatever happened. Now, why is that getting so popular? Or rather, it is already so popular. Why is that becoming socially inclusive? Because everybody can see it, everybody can talk about it. Speaking of things that we can see, if you get even smaller, a little pimple, and there is so many advertisements for acne and pimple removal and this and that and creams, and people accept it. Okay, you are in teenage, you gotta have pimples or whatever. There are times in your life that you have, and even a small thing which is practically invisible, a paper cut. You know, a paper cut, it's not even a blade cut. You don't even get blood out of it. But there's an instant shock the moment it cuts in. Ooh, there is a story created within. There's an emotion, there's a vibration that happens inside. And that makes it a conversation point. We talk about it. It is acceptable. Yes, if you work with paper, you will get cuts. If you work with wood, you will get cuts. No problem. Even though you can't see them. And speaking of things you can't see, got mental issues. You can see some of them. You can see people are getting defocused, forgetful, and anxious, all sorts of things. But when you go even deeper into emotional issues, the plot thickens. We don't want to talk about our depression. We don't want to talk about tendencies. We don't want to talk about things that are really bothering us from the inside. And we do it to ourselves. We don't put this kind of stuff on Facebook. We put our fat bellies on Facebook saying, I lost 3 kgs today, or this month. Let's go a level deeper. And this is our subject. And this is where you will see by the color, and I'll come to it in a moment, that we are entering a third realm, the purple realm, of very high subtlety. We can't even make out a lot of these issues. We can't even see them. We can't even measure them. And therefore, we can't control them as much. And Down syndrome is right down there. And that is the reason why social inclusion is so little. We don't know much about it. We don't want to talk much about it. We don't have enough to explore with, but it's there. And while the problem of inclusion is that we don't have clear-cut mechanisms about what as a society we have to do with people with Down syndrome, which is what I expect to cover in the next few minutes. The impact of the Down syndrome is high. If you look at it at the physical level, we're looking at being born with physical defects. We're even looking at early death. And that's where the body comes in. Now, this is where the color coding comes in. On the physical plane, the body. But in terms of mind, the person affected with Down syndrome from the time they were born has a lot of issues to cope with. Social issues, learning issues. They are considered different and not part of how we normally are. Now, it's okay for us to say who are not the bearers of the syndrome, but for the ones who are there bearing it, how do you think they feel? Ostracized for no cause of theirs? And if so, even more anxious. And again, we've got down to the subtle level. And obsessive. They don't know when to stop. They just keep doing it. Because they program that. And speaking of invisibility, this is one tiny chromosome. So that is the malady, my friends. That as things get more and more invisible, smaller in space and time, the social inclusiveness, it drops. But the impact, if you look at the red dot, that's probably the highest. Overweight will not cause you death as fast as Down syndrome would, right? Life expectancy. A paper cut would do nothing. Depression could be bad. And if you go up the ladder, Parkinson's. Fortunately, they come up a little later in life when the nerves get weak and we start getting rattled. But if you look at, as we go up the visibility spectrum, which is also, fortunately, unfortunately, our conversations, we find that the impact is lesser and lesser. And then the body issues, even lesser, as I said. So the fun thing is, I don't know whether it's fun, but the thing to observe is that this is in reverse. That means that if we want to increase the social inclusivity, the social inclusion of a symptom like Down's, a condition like Down's, to match the kind of impact that it has, and even that of neurological problems, we've got to look at this blue layer, what I define as the spirit layer. Now, we are all built with this trinity of body, mind, and spirit. The body we're very familiar with. We live in it. We are concerned about it. 2 kilos more, oops. Little pimple more, oops. Right? The mind we're not so familiar with. In fact, a lot of mind disorders we take as attitudes, as behaviors, as, you know, some things he's going senile, but he's not. It's a disorder. And we are not committing ourselves as much to looking at the disorder per se, and maybe techniques from ancient Oriental wisdom to rebalance the mind. Lesser still of the subtlest aspects, which are spirit, energy, neurology, the most subtle formation of our bodies. That's where, the closer we are to the way we were born as an energy packet, a little packet that entered with a genetic code, the closer we get to that, the lesser answers we have. So what can we do? And here's where I'd like you to look at the conversation. And the conversation, as you notice, is still way down, because it's not about increasing the quantity of the conversation. The solution lies in increasing the quality of the conversation. And the quality is compassion. That's the quality we want to bring in for social inclusiveness. What is compassion? This is a word bandied about. It actually means feeling, commiserating, feeling the pain, compassion, being in the suffering together. You feel somebody suffering. And because it's such an esoteric concept, nobody really knows, unless you're the Dalai Lama or Mother Teresa or somebody like that, how to be compassionate in daily life. So what I'm going to propose to you, and I would urge you to explore this yourself, since you would be meeting a lot of patients of the Down syndrome, and propagate this in your seminars, in your communities. And I'm most happy to be invited to speak with them as well, to show them how you can have certain ups for downs. What are the ups? U, P, and S. I'm going to give you 3 keys which will help bring a day-to-day level. U. Unconditional love. Remember, that kid is born with this for no fault of theirs. There's the wife and a politician in her own right, the wife of Roosevelt, and Eleanor Roosevelt, who very famously quoted that nobody can make you feel inferior without your consent. But she didn't think of these people, because they have not consented to this, not in this life at least. But they are made to feel inferior. While that may be happening in the larger part of society, if we can start with habits one-on-one, our own, our immediate circles, of loving these people, we will find that the reciprocation of their love is tremendous. People with Downs are more social. They are purer forms of energy. They've got a lot happening in their wiring, right? In their neurological wiring. That's a lot more energy flowing inside. Very subtle. We're not able to catch it. And to most of us, that appears weird. But this whole deal about love also is a little difficult to understand, isn't it? What does love mean? So to make it a little practical, let's just talk about acceptance. Can we accept them as a package? That this person is this way, and so they are special. That's what we want to build into our social communication. That's what we want to build into whatever tools we bring in. For example, I'm reminded of Martha and her son Henry. They were based in Spain and are. And Henry was being bullied in school. He was about 8, 10. And Martha couldn't do very much about the bullying. But what she could do is, she could accept Henry for whatever his shortcomings were, whatever his pains were. And she started doing that right from an early age, from the age of 3, 4. And when she sent him to school, she had a deal with him, a win-win deal. The Henry, whatever happens in your day, when you come back in, if you tell me everything about it, we will go to walk in the park together. We share everything. And so Martha would know everything that's happening to him and be able to take the appropriate measures with the authorities, with the teachers, with other people, and bring him up in a state of near normalcy. So by the time he was 10, that whole issue of bullying, which happened for about a year, 2 years from the age of 8, was behind him, and successfully, because he had the love and acceptance of an anchor person in his life. And what that takes is this attention. We as a society must just give our attention, and the love will happen automatically. Pay attention to what's happening in the surroundings and make it unconditional. You see, it sounds conditional. Conditional is also a funny word. It sounds conditional. That if you do this, then we go to the park. But that's not a condition. That's a win-win. If you do this, then we have food. That is condition. The park is happiness, is more endorphins being produced, is more oxytocin, is good bonding. But you know the problem with with attention, you need time, and that's where the P comes in. And the P, the most important factor of the P, the most important aspect is patience. And this is where a line from the Dalai Lama resounds so perfectly. He says that, he doesn't say it for Down syndrome, but he says that the people who bother you are actually your teachers of patience. So if that child is bothering, or in your mind you feel that way, he's actually your teacher of patience, he or she. How nice that is. You know, there was this CEO of a software company in Hyderabad, Jyoti Kapoor, and she was planning to have a baby at a 40+ age. And this is what the doctor said to her. That, look, Jyoti, you cannot expect to have a baby and continue life as it is anyway. But at this age, God forbid there's an eventuality, would you be willing to step down from the CEO's position and become a mom who really needs to take care of that baby and bring the baby up in a secure environment and be connected, demonstrate that connection? Jyoti agreed. And I know this couple personally. They had a okay baby, but I respect that doctor for that piece of advice, because in her mind she was ready for whatever eventuality might come. And that is what patience really means. It means you are getting ready, you're getting prepared, you're planning. All these are P's. Another P that is especially important is praise. As a society, we must look at acknowledging that whatever the person with Downs is doing, they are doing it in spite of a lot of energy inside, which is just going at like a bullet train. It's going at rocket speed. And they don't know how to stop it. But they're learning to stop it. And they're learning to conform with what we consider socially acceptable. So if they're getting anywhere close to that, we must acknowledge that. It costs nothing to praise. but it builds them up. That's quality conversation. That's where you're stretching the line of social inclusion. And that's where you are making that impact, which is so high on the person, a positive impact. Those energies of praise, of love, are going to bring the person into a happier state. And probably, obviously, right now we don't have scientific evidence of a lot of stuff that's been done in this direction, but I would love to do stuff like that. So if you're a researcher or a research institution or a university that is working on something like this, please call me over. I would like to see how habits, which I call the renewal habits, can be applied in this segment, and how that could result in faster mainstreaming of such people. Because mainstreaming is all about changing their subtle patterns. You call them neurological patterns, I call them energy patterns. They're basically at the level of spirit. That's what we're talking about. So we'd love to do stuff like that. And praise is very powerful. And there's a third P, which under all circumstances is a no-no. But unfortunately, as a society, that's what we tend to do. Pity. They do not need our pity. They do not deserve our pity. Even though energetically they may be far superior to us. They're processing a lot more. Don't know when to stop. And that brings me to the S of the ups for downs. Smile. Smiling is the one physical thing that anybody can do to raise the vibration of an interaction. You can never be angry or sad or depressed or ashamed or guilty or fearful and smile at the same time. So whatever you might be carrying within, whatever disgust or shame or sadness, to the person with Downs, if they see you smiling and they perceive that vibe, that you are a strong person, you can smile despite that. You are doing therapy. Each smile is therapeutic. That part, secure them. Make them feel that they belong, because everybody else is making them feel that they don't belong. You can make them feel that they belong. You can do it. And let's see how many other people see you as their inspiration. Can you? I'd love to see that. And keep it simple. If you're a parent or a teacher or a doctor, remember, whenever you're communicating, simplify it, visualify it, use multiple senses. Help them stick to a plan. Make it simple. Don't get them to do more than one thing at a time. I would say that for any human being, multitasking is not the way to productivity. But that's a different subject I can talk about in another forum. Single tasking, simplification, in terms of what you want to communicate and what you want them to know and feel. Let them know that you know that they have got it. It's a two-way feedback. It's not like we assume people to understand a lot of things, read between the lines and all that sort of stuff. It's not happening there, so don't force it on. They will appreciate you for it. They will grow with it. They will change with it. They may even mainstream with it. longevity might increase. And these are the social aspects for the future. Whatever has been happening in the past, if we adopt these kind of habits and this kind of approach to people with Downs, we've got to make substantial change right here, right now. Nothing else changes the quality of conversation through compassion. Thank you. This is a QR code. You can just point your camera at it and click on the Google Lens, and you will connect with my LinkedIn page. If you'd like to collaborate, if you'd like to do anything, if you'd like me to speak with you, please send me a message over LinkedIn and let's connect. Thank you so much. It's been an honor and a privilege. Thanks a lot. Have a great day.
So yes, so thank you to Mr. Sandeep Nath. His session has been really lively and filled with energy. And we had a different view of Down syndrome and how to communicate with such kind of people. It has been a very good session, and I wish he had joined us today in person through the virtual medium so we could have an even more knowledgeable session. So on that note, I would like to thank everyone that has joined us today, and a special thanks to all our three keynote speakers for giving us your time and for sharing your knowledge with us. I'm sure anyone that has been here has found this session to be very informative and knowledgeable. So on that note, I would just like to give the vote of thanks to everyone here. Now, thank you to all for participating in our webinar. And I would like to announce that you could stay tuned with us for more updates regarding the ACNM webinar and further conferences that are yet to happen. We have so many things in store for all of you. So as well, you can download your e-certificates over our ACNM dashboard that is available over the internet. And on that note, thank you to all that have joined us, and thank you to the organizers, and thank you to our scientific partners as well. I hope on this World Down Syndrome Awareness Day, we have had a lot of awareness, and we have also gained the knowledge that we can contribute to the world of Down syndrome as well. Yes, so we have a chat box message saying kindly send the link for downloading the certificate. So just a minute. Okay, so regarding the links for the downloading the certificates, so to all the people who have joined us for downloading your certificates, kindly leave in your email IDs on the chat box so that we can send you the link to download these certificates. So again, I repeat, kindly in the chat box, put down your email IDs so that we can send you the download link for downloading your certificates. Thank you, Sham. Thank you, Beck. Thank you, Sarah. Thank you, Rambabu. Thank you, Dr. Kushbu. Thank you, Sugashri. Thank you, Kartika. Thank you, Dinal. And thank you to Druvika. Thank you, Jeevan. Thank you, Sudeep. Thank you, Mona. Thank you, Jenny. Thank you, Shakti. All right. So the others, you can do the same as well. Similar, you can drop in on the chat box. So thank you all for joining us today. And it was wonderful hosting this webinar with all of you. Thank you for your participation. And thank you to all the keynote speakers again. And thank you to the partners and organizers as well. I hope all of you have a wonderful day today and we shall meet you soon. Thank you. Dear all, this slide has the information regarding for the contact information. So you can note this down in case of any further contact.